Good afternoon, ladies and gentlemen. Our webinar is going to begin. I'm Steve Love, President, CEO of the Dallas-Fort Worth Hospital Council. We really appreciate you joining us today for this educational webinar, and we're delighted that it's hosted in coordination with Skyward Rx, an associate member of the Council. And today's topic is how to drive new recurring revenue. Skyward Rx has an innovative pharmacy program that was created to allow hospitals to access over 605 plus medications for free at a low membership price. They've created a new concept related to paying nothing for some prescriptions. Through their strategic partnerships, buying power, and many generic medications, Skyward Rx is committed to helping you and your business and also save you money. Today, we're delighted that our guest speaker is Dave Rike, a founder and managing partner. And he's going to discuss ways new revenue via pharma, fintech programs, adding new patients through their national DTC programs, and doing other things to adhere to compliance data and to achieve verifiable, improved patient outcomes. So it's my pleasure now to introduce and turn this over to Dave Rike. Dave?
Well, thanks very much. I appreciate everyone's time today. My name, like I said, is Dave Rike. I'm with Skyward Rx. I'm one of the founding partners here. Today, I'm going to go through a number of different things that we do in the pharmacy space for our healthcare institutions. To give you a quick background, we've been around now for about 15 years. We've been across adherence and compliance programs for many facilities throughout the United States, and we run programs for direct-to-consumer, we run them for employer groups, and we run them for hospitals. And they're a little bit different depending on which way you look at it, but essentially it's all the same program. So I'm going to get into a little bit of each of these right now, and then we'll address some questions and such at the end. So starting off, there are really four areas, there's five really, and I'll get into the last one at the very end, but four main areas that we're going to focus on today. 340B, limited distribution drugs. I used Revlimid as an example. Employee specialty medications, and then our generic program and our employer Section 125 program. Starting off on the 340B side, we are a 340B pharmacy. We run 340B leakage programs today for some of the largest facilities in the US. We're currently working through agreements right now with the Cleveland Clinic for a very large project for their patients, as an example. We have a number of ways that we drive more patients to your contracted or internal pharmacies. So in the normal sense of 340B leakage, you'll see many companies out there in the marketplace today that will waive a copay if you have the patient go to your pharmacy. We do that, of course, too, but we actually extend it even further. What we've done is, instead of just covering a copay or making it a small financial incentive for the patient to change from a CVS or Walgreens over to the hospital's contracted pharmacy, we developed a rewards program. Our rewards program gives the patients, we waive their copays for their specialty medications. We give them their generics for free. We have other services like free telemed, mental health counseling, identity theft protection, a variety of other services. And we even send the patients a clinical survey each month, and then we're able to compensate them for their time in taking our surveys. So when a patient enters our environment, we have a custom patient engagement platform that is both in online and mobile experience. that will show the patients, if I'm going to get my, let's use Humira as an example because it's a very expensive medication. If I'm going to get my Humira, I can pay my $50 copay over here at CVS or Walgreens, or I can go to my healthcare facility's contracted pharmacy. My Humira is now free. My generics are free. I get telemedicine. I get these other health benefits now over and above for being part of this rewards program. So because of that, we're able to understand and change consumer behavior at a much higher level than what you're seeing in the marketplace today. Beyond that, we bring another unique perspective to the 340B leakage space. Beyond just addressing a hospital's current patients that they see today, we actually bring net new patients to hospitals. Because outside of our healthcare focus, we also, like I mentioned before, we run direct-to-consumer programs. We run employer group programs for their employee health benefits for self-insured employers. Those groups allow us to capture more patients that are on these specialty meds, and rather than fill them, let's say, in a drop ship mail order pharmacy type situation, we have the ability, because we have pockets of lives in, let's say, pick a state, Texas in this case, right? So we've got healthcare, or we've got employer groups throughout the state of Texas that, as we're working with their employees, they may be on a Humira, a Stelara, a Farxiga, one of these expensive specialty meds. And rather than have them fill that at CVS or Walgreens or drop ship that as a mail order pharmacy, we'd rather redirect them to our healthcare partners that we can then, send them to your contracted pharmacy. And that allows you then to capture those 340B savings from not only your existing patient base, but to capture net new patients and then bring them into the fold so that you can now capture them from a point of care, not just from a pharmaceutical standpoint. Our goal really is to make sure that we get patients involved so that we can get their medications to them quickly. We can make sure that they're well taken care of, and our partnerships with the hospitals, that back and forth there allows us to really make sure we are providing the best patient care. So that brings a little unique spin to the normal 340B leakage situation that you may see in the market today, where companies are just chasing those patients that you're seeing. We do that too, but we also bring you net new patients. Moving on to the next piece. Another thing that makes Skyward unique is that we have access to about 110 limited distribution medications. Limited distribution drugs are definitely difficult to come by in many senses. So I use Revlimid as an example here because it is a very big part of what we do with a lot of our hospital partners. Many of you may be familiar today with Revlimid as an oral oncology medication. Revlimid is only, and I may be off slightly by my numbers here, so don't quote me on this, but roughly 22 pharmacies in the US are approved to dispense Revlimid. Only 2 are approved for 340B. We're one of those 2. So that's a way that in many cases a hospital may be seeing patients, writing prescriptions for Revlimid, and maybe that is getting sent to an Onco 360 or somebody else, where those 340B reimbursement dollars are not coming back to the health system. If you're working with us, we'll have you sign our PSA and get that taken care of. The reimbursement there is significant. And so we have hospital partners that we're delivering millions of dollars per month in Revlimid alone. But like I said, there are at least 110 medications on our LDD formulary that we have access to, that we're happy to discuss how that could help your health system. Moving on, when we get into the employees, we bring a couple unique things. Now, many of the organizations we work with have a Cafeteria 125 program in place, but I thought I would bring it to the forefront just to at least mention for those of you who don't have it in place, or even if you do, ours may be different. So it's worth at least bringing up. And it brings us into the world of generic drugs as well. So when we get into our Cafeteria 125 program, as you may be well aware, a Section 125 cafeteria program is a FICA tax credit incentive program. It's a tax incentive program for paying for healthcare related services pre-tax. So not only does the health system get a FICA tax credit, but each employee makes more money on their paychecks. So each month, every employee will make roughly $125 more on their paycheck. So that's about $1,500 per year. For every 1,000 employees, the health system will get a $200,000 tax credit. Above and beyond all of the tax credits that are provided both to the health system and to their employees, we also provide a number of the benefits you see here. We cover all copays for preventative care, for primary care, for urgent care. We also have mental health and personal health counseling sessions that they don't have to pay copays for either. Dental and vision are discounted down at 80% below the standard cash price today. And then the biggest piece of this is all of your generic prescriptions are included. Now, if you have a cafeteria plan and you don't want to do this within it, we can do this outside of our cafeteria plan, but I'm going to go through it for this just for the sake of argument, and then I'll go back to that in just a second. But as part of the cafeteria plan, our generic program is wrapped into that. So this would eliminate all of your costs for generic medications for your company. Your company doesn't pay for the meds. This is outside of your insurance program. So this carved essentially out all of those generics directly to our program. And what happens is for chronic medications, we have over 480. I'll switch screens here real quick. For chronic medications, we have over 480 meds that are included in our formulary. All of these medications are delivered directly to the patient in 90-day supply. They are delivered at no copay, no cost to the employee. If it's wrapped into our Cafeteria 125, the health system is not paying for these either. It's just included in that. If they have an immediate need, obviously if you get the flu, you do not want to wait for me to ship you a Z-Pack or some cough medicine or something of that nature. So for any immediate needs, we have over 125 acute medications that they can pick up at their local pharmacy. So they can go to their CVS or their Walgreens or their HEB if they're in Texas, or Brookshire Brothers or one of those pharmacies. And they can get any of their medications there, and they show their card at the pharmacy, and those meds are given to them at no copay. As part of our cafeteria plan, this includes an entire family. So this is, mom, dad, 4 or 5 kids, doesn't matter. Everybody is included. So if we all know how if one child gets the flu, then everybody in the family ends up passing around the flu. So if you've got 4 kids and it's a mom and a dad situation here, you've got 6 people in a household. If everybody gets the flu and has 2 medications and they have $10 copays in a normal circumstance, this is a much less cost. They now have 0 copay for those medications. So this is an easy way to remove the barriers for employees to take their meds. So when we're in a Cafeteria 125 situation here, like I said, it is included into the plan. But beyond that, if you wanted to, let's say you have a Cafeteria 125 plan and you'd like to pay for this as opposed to going through your current PBM, This is an opportunity to have a flat rate per member per month fee for each and every one of your employees that would have their generic plan covered. So individuals pay $20 a month, families pay $30 a month, and it is capped at that. And whether that means the hospital pays for their employees at the 20 and the 30, or it's split between the hospital and the employee, or whether the employee picks it up, it doesn't necessarily matter. From our perspective, we give you the options to do it any way you really see fit. Our goal here is to deliver not just prescriptions, but here's an example. If you had 20,000 employees for your hospital, the health system is going to make $4.2 million in a tax credit. Your employees will make $30 million more on their paychecks, which is an average of $125 per month or $1,500 per year per employee. So you're talking about an overall impact between the employees and the health system of a $34 million to swing to the good for a 20,000 employee facility. On top of being able, from an HR perspective, to be able to wipe out copays for generics, for doctor visits, for counseling, and reduce the cost of vision and dental. When we bring that into the health system for your employees, like I said, it can be wrapped into 125, or it could be paid out separately at the rates of $20 and $30 per member per month. Beyond that, then, we look at your specialty drug spend. So we're not just around the generics, we're also involved in specialty medications. For the employee side, our specialty med formulary has over 225 specialty meds that are included in it. It is a white glove service. So when one of your employees joins our program, we do a 15-minute telemed visit with that employee. We understand some medications that they're on today. We move those medications to our pharmacy, and it is then a white glove service. So we ask that employee, when would you like to have your medication delivered? At that point, we set up the delivery for that day. We then call them the next day and make sure that they got their medications. We give them unlimited telemed access while they're on their medications with us. So night or day, if they've got questions, if they've got concerns, they can get a doctor on the phone or on their computer and ask questions. Many of the things that we're dealing with here are injectables. And so for those, we actually have a test, I would call it like a test pen, right? So if I use Humira as a good example, you have the Humira pen. Well, it's exactly the same thing. It's the same weight, same look, same feel. It just doesn't have a needle in it. And every time you put the cap back on it, it resets it. So you can act like you're giving yourself an injection and it looks like the medication is going in you, even though it's not. And it shows you how long it takes, what it kind of feels like, how hard do you have to push, things of that nature. Because if they're gonna go on this new medication, in many cases, these are, $5,000, $10,000 a month. You don't want them messing that up, right? Just because they're super uncomfortable giving themselves a shot. If you've never given yourself a shot the first time, it stinks. It's not a whole lot of fun, right? So if we can get them comfortable with that process, get a doctor to be on the phone with them when they do it the first couple of times, things like that are really promoting moving them to their medication more quickly and keeping them on longer. And what we found is that by doing that, we're able to then have a positive effect on the medical side of the equation. If we can keep them on their meds, essentially we can keep them out of their doctors and out of the hospitals, right? So those are ways that we are looking at to help reduce that burden on the patient. From the hospital side, we cut your cost for that specialty med a minimum of 20%. So we look at a dispense file, we'll sign a non-disclosure and a BAA with you and share a dispense file, and it takes me about 7 to 10 days, and we come back to you and we'll do a side-by-side comparison. Here's what you were paying for your specialty meds, here's what you will be paying. And then we're able to contract directly to those prices. So there's no smoke and mirrors, there's no questions on it. That's going to be your price. Our program can work with your current PBM, or it could be carved out. There's kind of a choice there. So depending on how you would like to run it, we have about 50 PBMs in our network today that we can run through. Some PBMs don't play as nicely as others, I guess you could say. And so for those, we would carve it out. In either sense, you have the choice. And I would tell you that, if you carve it out, obviously we don't charge admin fees. So if you're carving it out with us, you're not adding anything to the cost of the drug that we give you. So if you pay, let's say, net $5,000 for a Humira, right? I'm just throwing numbers out here. Don't quote me on prices, but if just using round numbers, if you're paying $5,000 for it, that can either be, if it's through your PBM, you're going to get your rebate on a quarterly basis. If it's carved out, you'll get that savings at point of sale when the employee refills the prescription. So there's an argument you could probably look at either way. One is maybe less disruptive because it's not a carve out, where the other is going to save you a little bit more money. I don't look at us as a PBM. That said, we can provide PBM services. So we are actually working with a couple of different healthcare institutions today to co-brand our program and incorporate it with their healthcare offering, so that we would be their PBM, so that way we can work directly with our healthcare providers on that. So there are opportunities out there if you're in that space where you have a health plan but you don't necessarily have a prescription plan. We can work with you there too. What you'll find about Skyward is that we're kind of like Legos, right? You can build the house any way you want it to look. A lot of what our engagement with you is sitting down and understanding, what do you have in place today? What would you like to continue to control and maintain, your lane in, and which would you like us to handle? And then we're very flexible in that. So it's not a one size fits all. It's not, you have to fit us in, our box. We'll work with a custom program that fits the needs of your specific institution. I brought up the medications that are in our generic program. Beyond the 125 acute meds and the 480 chronic medications that are included in this, we also give our members discounts on over-the-counter meds. Things like the generics for Tylenol and Allegra are roughly half price. We also have the cheapest price for insulin in America. Any member on our program gets their insulin for under $20 a vial. So we're trying to make massive strides in that. Walmart is our exclusive distributor for insulin. So anybody that is on our program can go to a Walmart, show their card, and they get their insulin for under 20 bucks. So our goal is really, and we're not making money off of this. So we're doing this because it's the right thing to do, because America has a diabetic problem. And so we're trying to promote good health across the board. So we don't think it's right for us to even profit off of that, to be quite honest. The last piece is for your employer group. We can run an analysis with a 12-month dispense file. We can show you side by side exactly what it's going to look like. And then we can build in options, whether it's with the cafeteria program or without, as it relates to generics. So that way you can see what the overall impact is. The last thing I'd like to address is we run direct-to-consumer programs. And so I've brought and I've talked about our $20 and our $30 program that's out in the marketplace. But to expand a little bit further on that, so just like what we offer to employees, or in the sense direct to the market, the 120 and the 480 meds, the 600 medications that we have out there that are free to them once they join our membership program, we have a list of about 20 specialty meds that if we're going direct to the consumer, we actually will give them our generic plan for free. So if we have a direct consumer in the market and they have a commercial health insurance plan, we'll put them on our program here and give them our generics. That's where we would drive them from a 340B leakage to one of your contracted pharmacies. But if they are in the market and they are in need of one of those specialty medications and they don't have insurance, we will actually go out and source them an ACA plan. We'll pay for their ACA plan for them. We'll cover their copay for their specialty meds, send them to you so that they can have those filled, and then we'll give them their generics. So our goal here is that, if you find in the market today, you may have a patient that's out there that has a need, and I'm going to stick on Humira because it's been my go-to med for my examples here. But let's say you have a patient in the market and they have a need for Humira. If they don't have health insurance because they can't afford it, they certainly can't afford Humira. And if they can't afford health insurance and they can't afford the Humira, that means they're not going to take it. And what that means is they're going to end up in your hospital. And when they end up in your hospital, you guys are going to do exactly what you always do, and you're going to help them, right? Because we live in America, and that's what we do for our patients. We help them. So you're going to help them, you're going to make them feel better, but now you just racked up a bill that they also can't afford. And they're not going to pay it probably because they didn't have insurance and they couldn't afford the Humira either, and they certainly can't afford this $40 or $50 or $80 or $100,000 bill that they just got. So that means that the hospital system is going to have to write that off, and that costs money. So our goal is to, when we see these folks in the marketplace, to get them insured, because, number one, we would like them to keep them out of the hospital, right? So if I can get them insured and I can get them on their Humira, hopefully in this situation here, right, I can keep them out of your hospital. But God forbid that they do have to go to the hospital for whatever reason. At least at that point, they're now insured. So now you're not in a situation where you're going to have to write off these things too. So our direct-to-consumer program not only brings the opportunities for you guys to leverage 340B and drive more 340B savings in your direction, but it also helps the general market in your area for people who are uninsured but have high levels of need for these types of medications to be on a program, get insurance, and then cover some things that, that also really ultimately end up covering you as well. And that's really what we're trying to do in the marketplace to change this. Our program is being private labeled direct to consumer across a number of different brands. You likely won't see the Skyward name as much as you will see other names in the marketplace. We're currently finalizing an agreement to do a program for Health Connect for AAA and ProMedica. We're working with the folks at the NFL alumni to run a direct-to-consumer program using the NFL Shield behind it. We have American Senior Benefits, who handles 700,000 seniors nationwide. We have a group that has 600,000 brokers that are all of these programs are being private labeled across the U.S. So our direct-to-consumer program will touch about 50 million Americans by the end of summer this year. Those are all opportunities of net new patients that we can bring to the hospital systems throughout the DFW Hospital Council. And that is really what we're trying to do here to help the patients get better care, help the hospitals be more financially stable, drive the revenue to you so that you can then take better care of the community. And that's really what our goal here is at Skyward. We do not charge for our services. So we're not coming in and saying, I need $500,000 or I need $1 million or I need something like that to run these programs. We go at risk because we understand the impact that we're going to drive. So in all of our cases, we are either compensated on the back end through our dispense fees at our pharmacy or through a revenue share with our hospital partners for the things that we are bringing as far as net new revenue, net new 340B savings, whatever you want to call it. So on the 340B side, our rewards program is paid for out of our side. We cover all of the fees of these things. And, you know, we sit in a very unique space because we're able to put these programs together where it would be illegal for a hospital to do it in some cases. So it allows us to drive the savings and drive the patient value that we're really looking for. And with that, I will open it up to questions.
Yeah, and Dave, this is Steve. Thanks for a great presentation. For the participants, if you have a question, please put it either in the question box or in the chat box. And we do have our first question, Dave, and it is, can you function in my hospital alongside my current pharmacy benefit manager?
We can, and there are over 50 pharmacy benefit managers that are currently in our network today. And so we are able to access all of those and run as a complementary program. So this is just additional savings. So as a great example of that, let's say that your PBM today is giving you a 20% rebate on your drug spend. Well, when we add our savings in there, it is just going to increase that 20% rebate and add another 20% to that. So when we work with your PBM, it is just a nice complementary additional savings that we're providing above and beyond what they're giving you today.
Okay, here's another question we just got. Can you work in CAHs and small hospitals, critical access hospitals and small hospitals?
Absolutely. 100%. We can really work with any size hospital. And I brought up a lot around 340B, but I should bring it up that we don't have to be working with 340B hospitals either. So if you are not a 340B eligible hospital, that's okay. There's still a lot of things that we can do both for your employees and even through a coordination of care with an FQHC for your current hospital that's not 340B. But we definitely work with small hospitals.
Great. You know, you mentioned 340B, so here's just a direct question that we just got. Dave, can you really differentiate how you're different than other 340B leakage solution providers?
Sure. So most 340B leakage solution providers are only focused on the patients that your health system is internally seeing. They only operate amongst the four walls that you have around you. So if this is not a patient that is currently going to your hospital or one of your associated clinics that is tied to your hospital, then it's not a patient that you are going to capture from a quote unquote leakage standpoint. What we do is we capture those people just like those other companies do, but we bring a new sense to it. Let's say, you know, you're in Houston okay, as an example. I know this is Dallas Fort Worth, but let's just say, for example, you're in Houston and we do an employer group that is in and around Houston. Well, now I have, let's say that employer group has 10,000 employees. If they
And
have
you
10,000,
said,
if they have 10,000 employees, I'm identifying about 3% of their employee population is going to be on a specialty med. When they go fill those meds, rather than me drop shipping them to them, I would drive them to one of your hospital's pharmacies. So now that is a net new patient that may not have been a current existing patient of your hospital. When I'm doing my direct-to-consumer program, like we're working with a couple cell phone carriers. Okay, so if I'm working with a cell phone carrier and they build the cost of my generic program into the cost of their cell phone bill, I'm going to be identifying anybody that's on my generic program that is taking specialty meds. Those would be the 340B meds that you're looking for, right? And so now I've got a bunch of people, let's say that's on Verizon and they're in Dallas. I've got a person that signs up because they now are on the Verizon plan. Well, I identify that they're on Humira. Well, I should send them to one of the DFW Hospital Council's institutions so that they can get those meds filled. And that allows me to drive that. And then that hospital captures that 340B savings for that patient that they didn't see. They didn't write that prescription to begin with. So the other 340B guys are only chasing those prescriptions that you're writing today. Yeah, we'll chase those too, right? We chase those patients too, but we're also bringing new ones from employer groups and direct-to-consumer groups, and nobody else in the marketplace is doing direct-to-consumer. Nobody does, except for us.
thank you. You know, I'm just going to remind people, we're getting a few, but if you do have a question, please indicate it in either the chat box or the question box. And Dave, I know you touched on this in your presentation, but this question is, you do have access to LDD meds, is that correct?
We do. We have access to over 110 LDD meds. I used Revlimid as an example, but there's an incredible list more that we have access to. And I know a lot of hospitals don't have access to that. So that's something that we would love to discuss with any health system. If they have any challenges around LDD meds, please let's have a discussion, because that's something that we're very in tune with. We do and to bring a little perspective for everybody, we've got a number of pharmacies across the U.S. We do in about, out of our specialty pharmacy, we're doing about $1.2 billion worth of dispenses today. And we do about 40% or so is oncology. So we're very big in the oncology space outside, you know, and part of that is LDD, but there are other meds out in LDD that are included as well.
You know, Dave, here's a question that came in as you were doing your presentation, and I think you might have answered it at the end, but it's certainly worth repeating. And the question was, how much do you charge hospitals for your services?
We don't charge. So when we come in, if we're doing like 340B leakage, we take a percentage of the savings that we drive back to the health system. So if we don't drive any new patients to you, we don't make any money. If we are successful and drive patients to you, as we are with every other hospital, then we would get a portion of that savings. Beyond that, though, in the employer group side, on the generic side, there are no costs. We don't charge anything to set up the Cafeteria 125 program. We don't charge anything to set up our employer group programs. All of that is just included in our service for what we do. We're compensated, you know, on the employee side. We make our money, just being completely honest with everybody. On the generic side, you know, we understand who's filling what, right? So if we have a member that pays $20 or a family that pays $30, some months we may win, some months we may lose, depending on how many medications that family or that individual takes. But we're compensated out of that side. We don't charge admin fees. We're not coming in and saying you need to pay us, $100,000 or $1 million or anything like that to run our programs. We're confident in our ability to deliver.
Thank you. This question also was put in early on, but I just want to give you the opportunity because I think you covered it. It said, are you primarily focused on 340B, or do you have other offerings in the pharmacy healthcare space that would be beneficial to hospitals? And I know you covered a lot of them, but I just thought I would read that question one more time.
Sure. We do. We actually have some other things that I didn't cover here. We're a fairly large organization, so we're involved in the compounding space. I know that there's a lot of interest and news around semaglutide. We handle lots of patients for that. Ozempic is on our specialty formulary. So if you've got patients that are on that, of course, those are all big news names. We're very involved in the HRT space and some other spaces like that. But I think the one thing that is probably unique that I should bring up is we've been running adherence and compliance programs for drug companies for 15 years, 20 years now. One of the systems that we have is the ability for health systems to capture biometrics on a patient. We give the patient either a Fitbit or an Apple Watch, and within that, we're able to capture, we need to capture, I believe it's like 15 or 16 biometrics that create the ability for you to bill their insurance for adherence and compliance. It's about a $69 charge per patient per month that you're able to do this for. And what we're able to do through our program is we give the patients these Fitbits or Apple Watches and have a commitment on their side for their using them. And we're able to then capture those biometrics, and between delivering that information to you so that you can provide better care as a hospital, but also it creates a billing event from an insurance standpoint. And I believe Medicare, Medicaid is up to, I believe it's like $69 per member per patient per month. Then if you do a telemedicine visit with them, it's another $50 or so. So let's call it roughly $100 per patient per month billing opportunity because of this. And this is every patient. It's not just Medicaid and Medicare. It's every patient that can be seen. So if you have a hospital, and let's say that they have 100,000 patients, and I'm just using nice round numbers here. If you got 100,000 patients and you're billing them, that's $10 million at $100 a month. That's $10 million a month in new billing that is created. Now, of course, we take a portion of that as well, but it is a nice revenue driver, but it's also a way to really have better information about what's going on with those patients. Beyond that, our database allows us to search every prescription, doctor's, whether it was filled or not filled, every doctor's note, every lab, and everything that patients had, regardless of where that facility is. So if they lived in Seattle for a while, and then they lived in Atlanta, and then they moved to Dallas, and now you're treating them, right? We will have, our system would be able to have access to every note historically for that patient, so that we're able to provide those to the hospital for better care. So there's some things like that we can do that is a little more unique outside of just providing medications. We're all about finding ways to drive new revenue to support our hospitals. You know, in rural healthcare today, hospitals are really struggling, and everybody here probably knows that COVID put a hole in everyone's balance sheet the size of the Grand Canyon. So between non-elective surgeries and paying nurses 3 times what their normal costs are, it didn't exactly bode well for everybody's bottom line. So while every health system out there is hurting, we look at this as the time is now for us to be able to show every system we can how can they derive more money, more savings to their facilities so that we can get everybody back in great financial shape to take care of these patients. That's our goal.
Yeah, Dave, I think you mentioned a very important thing, not only drive revenue, but help reduce expenses and save money. So you kind of hit both sides of the equation. Is that a fair assessment?
Absolutely. Yeah, we are all about both sides of that. If we can drop cost out, we want to do that. And if we can drive revenue, we want to do that. Our goal is just not to come in and impose fees. If we can start stripping some of the costs that are in the system out and delivering that back to the health systems, to the patients, to the employer groups, that kind of thing, it's really where that needs to be. And it's honestly, the revenue has been held up by a handful of companies for a lot of years.
Well, Dave, Chris is checking. I think we've completed all the questions that we've seen in the chat and also in the question box. He's checking one last time, but I think we've covered everything. There were some really good questions. But we're going to certainly give you a moment to thank you for this presentation. Thank you for answering the questions. And we're going to give you the last word. Do you have any closing comments before we end the webinar?
Well, I certainly appreciate you having us. I really do thank you for that. Our goal really in the market is to change the way everyone looks at prescription drugs. Whether that's the consumer that's actually the patient taking the meds, or the employer groups that are having to pay lots of money for it, or ultimately really you guys, the hospitals who take care of everybody. Everyone has, if you look at the news, everyone sees the high cost of medications and complains about it. We're trying to do something about it. And if we can do something about it to help the patients and at the same time help our healthcare institutions make more money or save more money, I think that's where the win really needs to be. And so if there's anything we can do to help, we would love to help you. Certainly, please reach out to us, and we'd be happy to help any way we can.
Dave, thank you very much. Excellent presentation. And to the attendees, all the people that registered, not only maybe people had something come up at the last minute and they missed, Chris Wilson, who does a great job with these, is going to make sure that this session recorded is sent to every attendee tomorrow. Is that correct, Chris?
Yeah, that's correct.
Okay. So you will get a complete recorded copy of this tomorrow. And we certainly appreciate all the people that participated. We think these webinars are so worthwhile. And on behalf of the Hospital Council, we certainly want to especially thank Dave and Skyward Rx for this webinar. So this concludes it. Everyone be safe and be healthy.
Thanks, everybody.